Welcome to the BeWell Network program. My name is Dr. Ted Bender. I'm a clinical psychologist and the CEO of the BeWell Network. You can always learn more about me at BeWellNetwork.com. Our number is 888-743-3751. My goal, as always, in this program is to educate people and to help as many people understand that they are not alone. There is help for the many life obstacles that we endure. Today, our topic is suicide awareness. It is my great honor to have Dr. Gordon as our special guest. She is a clinical psychologist, author, and has worked as a professor in the field of clinical psychology. Thank you, Dr. Gordon, for being on today. Your book, the Suicidal Thoughts Workbook, CBT Skills to Reduce Emotional Pain, Increase Hope, and Prevent Suicide, is now available online. Let's dive into your book, and thank you again for joining us today.
Thank you so much for having me on.
Dr. Gordon, I have to say with all sincerity that this is one of the best self-help treatment workbooks that I have ever read. And I wanted to know, first of all, what inspired you to write this book?
Thank you so much for your kind words. I think that what really inspired me, I've been working in the field of suicide prevention for years now. And one thing that we see out in the world is that there are many more people who need help than who can access it. And one of the issues with that is that it's sometimes hard to find therapists in one's area or that are covered. And it's even harder sometimes to find therapists who are specifically trained in helping people with suicidal thoughts. So the idea with this workbook was to take the best of the knowledge from science and clinical wisdom and therapy and put it in a workbook that people could easily access themselves, and that way they could learn about the nature of suicidal thoughts and learn some real tools to improve their lives. So that's the main goal of the book.
Absolutely. Something that I think about all the time, and I feel like I got a really kind of good answer from reading your book, is that there's so much research and there's been a lot of resources that have been devoted to suicide research, although maybe not enough. Still, significant advancements have been made in our understanding of suicide and its related behaviors. Why do you think then that the rates have continued to rise despite of all of our advancements in knowledge and assessment?
That's such a great question. I think that part of the issue is that suicide is an outcome that's determined by a lot of different factors and a lot of different pathways. So it's true that we can have good intervention methods that help people and prevent suicide for many people, and yet still have others who are experiencing very difficult things where those are inadequate or they can't access them. So I think that it's true that while we've made these advances and they have helped many people, because of the number of stressors that exist in the world, you can still see suicide rates within the United States, see them rise.
Yes, absolutely. You talk a lot about the 3ST model in your book, something I found particularly fascinating. Can you break that down for us and tell our listeners what that is and what it means?
Absolutely. So the three-step theory was first developed and written about by Klonsky and May in 2015. And what they did is they acknowledged that people can arrive at suicidal desire and suicidal behavior through different pathways, but there are three commonalities that might be true across experiences. And the first step suggests that for someone to desire suicide, it means that they're in a lot of pain. That can be emotional pain, physical pain, psychological pain, and they're hopeless about that pain ever getting better. And it's understandable if someone is in excruciating pain and feeling hopeless about getting better, they might start thinking about suicide as a way to escape that pain. Within the three-step theory, there's then a second step. And the suggestion is that while many people who develop suicidal thoughts will not go on to attempt suicide, and one reason for that is the second step. There is a layer there that looks at connections to life. And those can be to people, relationship, values, whatever it might be. And so the idea is even if someone is in a lot of pain and feeling hopeless, if they have connections to life, then they may not attempt suicide. Whereas if their pain is exceeding their connections to life, then they're at higher risk and move into more severe suicidal desire. And then the third step talks about capability for suicide, which is from the Interpersonal Theory of Suicide by Thomas Joyner and colleagues. And that suggests that because enacting lethal self-injury, hurting oneself, goes against the survival instinct, many of us are protected from ever acting on suicidal desire should we have it. So the third step suggests that the people at highest risk for attempting suicide are those who have those first two steps, and in addition to that, have capability for attempting suicide. Maybe they have access to lethal means, guns, overdosing, whatever it might be, and they have a lowered fear about dying or the pain involved.
Absolutely. It's that acquired ability piece that must be present, coupled with the desire, that puts someone at kind of a crisis level. And you mention in your book what it means to actually be in crisis and kind of what to do when that happens. You and I have spent years as suicide researchers and working with patients who are struggling with suicide in practice. I get this question a lot, and I'm sure you do as well, from family members. What should I be looking for? What does a suicidal crisis even look like? And more importantly, what do I do when I recognize it?
It's a great question. There are a lot of, it can look different depending on the person, but there are some common signs that we see when people are in suicidal crisis. One is that they're thinking a lot about death and planning and maybe even talking about suicide. But other things that we tend to see are sleep disruptions, maybe worsened insomnia or nightmares. Withdrawal is a big one. When kind of isolating from other people, you can see that as well. A sense of feeling trapped or hopeless that things will get better. Those can be a lot of the warning signs about crisis. And what can be helpful in that situation is really to try to connect with the person in a way that's non-judgmental and that understands what is driving that pain in the first place. And then alongside them, coming up with ways to support them or help them through it. And that can include things like safety, for example, removing lethal means by which they might hurt themselves. But it can also include other things like helping them get set up with a therapist or just spending time with them. And those types of things can be very helpful.
You mentioned in another important area, means restriction, which for our listeners, basically what that means is removing the ability for someone to make an attempt, whether that's handguns or sharp objects or large amounts of pills or many other things. What do you say to people that say, well, we could do all that, but if someone wants to make an attempt or to die by suicide, there's no stopping them. You can't do anything about it.
That's a completely understandable way of thinking, but what the research shows is actually when people are in crisis at the highest level, for many people, it's a constrained amount of time. And if they do not have access to a dangerous way to hurt themselves, then that crisis level can decrease without having them actually attempt suicide. So it's true that some people will go on to find another method, but many people will not. There's also something where it seems like people might prefer or feel most comfortable with a certain method. So if they don't have access to that, it can be very life-saving in that moment.
That's interesting. So basically, if I'm hearing you correctly, the means restriction itself can thwart an attempt just because some people are more comfortable or have maybe even kind of practiced in their mind how they would do it. And if that method has been thwarted or removed, it may save or prevent an attempt.
That's right. And one of the clear examples we see of that are when they put barriers on bridges. And if someone plans to jump from a bridge and they have a barrier, some people will go to another method, but lives are saved by barriers, and that it does prevent some people from attempting suicide.
Dr. Gordon, as the CEO of a mental health and substance use disorder company, when I was reading through your manual, I got really excited about the implications for utilizing this workbook in therapy. So what are your thoughts on how therapists and clinicians can use this book with their patients who may be at risk? How would you implement that in therapeutic practice?
I'm glad that you said that, because the two audiences I had in mind, one were for the most importantly people struggling with suicidal thoughts directly to have it, but also for therapists to feel like they have tools and knowledge to be able to help people. And so the way that the workbook is set up, it is designed to kind of parallel therapy, and that the first thing is setting up a crisis plan. And that's really important for anyone who's at suicide risk, to have numbers that they can call, to have people they can contact, and have ways to kind of immediately soothe that crisis and to get through that. But then I also recommend, in a collaborative way, the therapist talking to the patient about what areas they're most concerned about. Are they experiencing hopelessness? Are they experiencing emotional pain? Is there loneliness? And there are chapters broken down for each of those points. And that way you can tailor it individually for that patient, which can be a very validating experience. Suicide prevention is not a one size fits all, and yet there tend to be these common factors. So those would be my recommendations, is that kind of come to it together, select an area, and work through that.
Got you. That makes a lot of sense. What do you think are some of the biggest risk factors for someone to get to a point where they are contemplating taking their own lives or making an attempt on their lives?
I think the biggest one is that excruciating pain and seeing no other options when someone feels that they really there is nothing in their future that looks bright, that they don't have anything to hold on to, anything to look forward to. And then when they start, if you pair that with planning specifically about how they're going to attempt or hurt themselves, that becomes a very dangerous time. In addition, one kind of warning sign I might add that I didn't mention before is that often people, when they're feeling that kind of high level of suicidal crisis, also will describe feeling agitated, like they're going to crawl out of their skin. And so that's another sign that things are escalating.
Sleep disorders, and particularly nightmares, have also been identified as potential risk factors. What should people do if they're struggling with insomnia or nightmares or both?
The good news is that we do have effective therapeutic treatments that are evidence-based for both nightmares and for insomnia. Cognitive behavioral therapy for insomnia can be very effective. There are therapists who do it. In addition to that, there's a free app through the Veterans Affairs Administration that people can access, and there are self-help books. With regard to nightmares, sometimes those come from trauma and post-traumatic stress disorder, and there are some options there that can help people really address those, and that can help reduce suicide risk.
That was another thing I loved about your workbook, is when it started to get into other areas like that or obsessive compulsive disorder, you immediately diverted the audience's attention or the reader's attention to other resources in the back of the manual, which I really loved. I thought that was really well done, Dr. Gordon.
Thank you.
In a previous episode on the BeWell podcast, we interviewed champion boxer Mia St. John, who tragically lost both her son and ex-husband to suicide. She commented on some of the myths surrounding suicide that tend to be really prevalent in people's minds. And I've certainly heard these many, many times working with suicide decedents or family members of people that died by suicide. They often blame themselves. They feel like they should have seen it coming. Everybody seems to think that there's always a suicide note, which is definitely not always the case. What do you think are some of the bigger myths or misconceptions that the public tends to believe about suicide and that we can clear up here?
I'm glad you brought that up. One thing that I try to point out in the book is that though it's important to talk about warning signs and checking in with loved ones, we all have limitations in terms of what we can do. And so it's important to not blame yourselves if you find that someone you love is being affected by suicidal thoughts. We can all do our best to connect and check in with them, but sometimes we don't really know what they're going through, or we aren't able to help them through that suffering. And so I think it's important to have that balance there. In terms of other myths surrounding suicide, I do think that sometimes people still will feel, I sometimes see this in the media, if celebrities have children, for example, and die by suicide, that they'll feel that was a selfish thing to do. And I kind of get why they think that. And yet when someone is suicidal, they often think that they're doing their children a favor by leaving the world. And so it's hard to understand that if you're not in the suicidal mindset, but it's important to have some compassion for the idea that people may mistakenly believe they're a burden on others. And that's why they make that. And that's why they're driven to suicide.
That's one of the more common distortions that people who are suffering from suicidality often have, is they believe wholeheartedly that they are a burden on others, and genuinely that people in their lives will be better off if they were gone. And it's hard to understand that if you're not going through those types of thought errors or thought distortions yourself. But if you truly believe those thoughts to your core, you can start to understand why some people might be led down that path.
Absolutely.
Another thing you mentioned in your workbook was non-suicidal self-injury. Tell us a little bit about what that is and how it differs from suicidal behavior.
Sure. Non-suicidal self-injury is when someone intentionally inflicts some harm on their body tissue. Common ways are by cutting or by burning themselves. And the reason it's non-suicidal self-injury is that it is without the intent to die. So the person will often say that they're doing that because they want to get rid of some negative emotions. And there are different kind of ideas in the research about the effects of that. Some people have talked about how we're kind of driven to pay attention to injury. So if you're hurting yourself, your mind might shift attention from the emotional pain to the physical pain. And so that's often what people will say. And it is related to suicide risk in that people who tend to self-injure are at elevated risk for suicide.
Because that ties right back into the ability you mentioned, which was the other piece besides the desire for suicide.
Absolutely right. For people who are on a regular basis hurting themselves or kind of pushing past our natural aversion to physical pain and can become habituated or used to that.
Isn't it true that one of the most fundamental drives of really human life and a lot of life on this planet is survival? Another one of those myths that I hear quite often is that, oh, they just took the easy way out. Is there any truth to that at all, especially with what we just said?
I think that thankfully suicide is difficult because I think that we would lose more people
Agreed.
if it was easier for people to die by suicide. But most of us have a pretty strong intact survival instinct, which just shows how much severe pain people are in when they overcome that.
If you had to sum it up into maybe the top 3 or top 4 significant risk factors for suicidality, what are some of the stronger risk factors that you've seen in your research and your work?
I think some of the main ones are there are people who struggle with chronic medical illnesses can be at elevated risk for suicide. People who struggle with substance use problems can be at elevated risk for suicide. And there does seem to be also these other types of factors such as unemployment, divorce, those kinds of things can also increase suicide risk.
Are there certain demographics or people that have higher risks for suicide than others?
Within the United States, death by suicide tends to be highest among white men and for adults and also Native American men, whereas we do see higher attempt rates among women. When we look at younger age groups such as children and adolescents, that does change a bit where we tend to see higher rates among Black children in recent research.
It's interesting you mentioned that there are more attempts by females, yet more completed suicide by males. Can you talk a little bit about that?
Sure, there are different ideas about that. One of the main factors appears to be that men, when they do attempt suicide, are more likely to use lethal methods like firearms, whereas women might be more likely to overdose. So that's thought to be one of the factors that explains or underlies that discrepancy.
Dr. Gordon, the suicide rates in the United States have been escalating since the year 2000. From 2000 to 2018, it's been pretty much straight up. Has there been any shift or change in the most at-risk age group as we've gone along since 2000?
Did appear for a certain period of time that people who were ages 85 and older were at highest risk for suicide. And then in more recent years, we see more of a peak in middle age, for example, ages 45 to 54 among adults for being among the highest risk group for death by suicide in the United States.
That's interesting. Is there any indication as to why that shift is taking place, or have you seen anything that shows why we've kind of led down that road?
It's a really good question, and I have not seen any very clear answers about why that is. I think one of the difficulties in studying suicide is that once you kind of see the broad statistics, it takes so long to dig into it that it can actually be a big challenge, I think, in making as much and as rapid progress as we'd like to effectively intervene.
I think a lot of our listeners that are out there listening to this podcast right now that have a friend or family member that they think might be struggling, or maybe they're struggling themselves, often want to know what the signs and symptoms of suicide are. So if I'm a family member, if I'm a mom and I'm concerned about my 18-year-old son, for example, or I think they may be using drugs, I don't know what's going on, what should I be looking for?
I would look for any differences in mood changes that are kind of consistent. I mean, depending on the age and time of life, and all of us are under extra stressors with the pandemic. But if someone just seems like they're not themselves, it's good to check in and try to understand what's going on with them and have some patience with that. I think that sometimes we can ask if someone's okay and they say it's okay, and we kind of back off. But I think it can be helpful to just regularly talk in conversations and let the person know that it's a safe, non-judgmental space for them to really share what's going on with them, and that you're there for them. You want to understand what they're thinking about, how they're doing.
And that conversation can be very difficult for anybody to have, family members, friends, whoever it is. Another one of those myths that pop up a lot that I hear quite often, and I've heard in my career that you very likely have as well, is that if I ask them if they're having thoughts about self-harm or suicide, it's just going to make them worse or more likely to do that. Is there any truth to that, and how have you dealt with that when people have asked you?
I'm really glad you brought that up, because you're right, that is something that people worry about. I think that's especially true that people worry about asking children or adolescents directly about suicide, that they'll think they'll plant the idea in their head. The research suggests that there isn't risk of that on average. What tends to happen is if someone is not thinking about suicide and you ask them about it, you probably won't see any change. However, if they are thinking about it, they may experience relief just by knowing that it's okay. So I do recommend talking directly to people about suicide, even if it does feel uncomfortable, because it's a scary thing to think about a loved one going through that.
So if I'm hearing you correctly, and just to kind of paraphrase, not only is it not a damaging or a negative, it can actually be a positive, because people think, hey, someone cares, someone's reaching out to me, I'm not alone in this.
Yes, and it sends a message that it's not unspeakable, that we can acknowledge difficult things, including painful things and suicidal thoughts. Millions of people experience suicidal thoughts every year, and just knowing that someone's not alone in that and it's something you can discuss, that can really open up a connection for someone being willing to ask for help.
Yeah, and working in the substance use disorder field like I do, it is more common these days for people to either know someone who's struggling with substance use disorder or be struggling with substance use disorders themselves than to not. Almost everybody that I talk to, everybody I know, knows somebody who's going through this. And one of the staggering statistics that I read in your workbook was that it is estimated now that 9.8% of all Americans have seriously considered suicide. That really blew my mind. I mean, we're talking almost 10% of the country now has at one point seriously considered suicide. What does that mean, to seriously consider it? What's the difference between having a passive, fleeting thought here and there versus serious consideration?
That's a great question, because for many people, even people who've never felt suicidal, they might have the thought when they're going through a really hard time that they don't want to wake up the next morning, or they wouldn't mind if an accident happened or something like that. But to seriously consider suicide is more of an active type of thought, where the person might be thinking about how they might die by suicide, or they might be thinking about it more frequently.
So a serious consideration may be not just a fleeting thought here or there, but to the point where you're thinking about it more and more, maybe creating a plan for how you would do it. Is that what you're saying?
Yes, that's right.
And for people that are suffering from thoughts of suicide or thoughts of self-harm, what are some of the more distorted thinking patterns that they tend to endure? So for those of you who don't know what that means or what we're talking about, lots of mental health disorders people suffer from distorted thoughts or thought errors or thinking errors. In the treatment industry and as psychologists, we call them cognitive distortions. And people who are suffering from suicidality or having suicidal thoughts have quite a bit of these happening and going on, and they have a lot of these distorted thoughts very often. What are some of the more common distorted thinking patterns that have been identified in the suicide research?
When someone is feeling suicidal, they can experience what can feel like a tunnel vision where they can't see any of the positives ahead in their lives, or even see any positives when they look back on their lives. And so it can feel very bleak and awful. And so all or nothing thinking might be one way to put that, where it's not thinking about there are valid, difficult things in my life and there are positive things, but rather only those negative things. Now it's automatic. People are not doing this on purpose. When someone's suicidal, their mind is doing that without them doing that intentionally. But what happens is they tend to focus on the negative things, and that increases the pain. Another common thinking pattern that we talked about before is feeling like a burden, like I'm not worthwhile being around anymore, or that people would benefit from me being gone. And that's a very sad and painful thinking pattern. And if I had to add one other, I think that it would be a pattern of a belief that things can never get better, and kind of that could be called fortune telling or looking ahead. And so a big theme of the book talks about specific strategies and small practical steps for building hope and belief that things can get better, because that hope can be protective against suicide.
Dr. Gordon, there's a lot of really excellent treatment available for people who are suffering from mental health disorders. What are some of the frontline treatments for people who are suffering from suicidality or thoughts of suicide?
Some of the major ones are cognitive behavioral therapy for suicide prevention, dialectical behavior therapy, and collaborative assessment and management of suicidality, or CAMS.
Talk a little bit about CAMS. What is CAMS, and how does it help people who are in this situation?
Well, CAMS is a framework for treating suicidal thoughts that really involves the collaborative part is emphasized, and the clinician really joins with the patient to try to understand what is driving the suicidal behavior, including looking at things like hopelessness, and then working together to improve their life and find things that make it worth living. And so it's a very collaborative approach. It's very direct, and it's very flexible and tailored to the individual.
Dr. Gordon, during the pandemic and through the pandemic, and now that we seem to be heading into our third year of COVID, which is just unbelievable to say out loud, what are the most common issues you're seeing in therapy today?
The most common issues, I think, are maintaining a sense of hope when a new COVID strain is coming, or things feel like they're getting back to normal with a vaccine, but then having breakthrough cases. And so I think that a lot of what I see is the challenge of keeping an optimism and enjoying things in life without feeling bogged down and overwhelmed by all of the many pressing issues going on.
Yeah, when this whole thing started, I was thinking to myself, what would be the worst possible scenario for people who are suffering from mental health disorders and substance use disorders? And really, if you put this into a closed system, it would be economic downturn and social isolation. This is exactly what COVID has brought not only to the United States, but to the world, those two specific ingredients. And as 2020 was kicking off, and March turned into April, and April turned into May, and we didn't really know what we were dealing with, I was doing a lot of outreach on encouraging people to take care of themselves, because I kind of could see what was coming. And lo and behold, we saw the worst ever overdose death rate in a single year in our country's history. And interestingly, suicide rates, I believe, did drop a little bit that year, and I'm not sure where it's at today. So we have this situation where we're still in this. We still have a lot of social isolation. Some people haven't seen their family members in years. And the economy is kind of doing this up and down thing for quite a while now. What do you think is the future of mental health issues or problems if this continues to just languish on and on for years to come?
I'm very concerned about the amount of grief people are going to have because of loved ones that they've lost. There are children who have lost their parents. There are people who've had long COVID, and they survived, but they have permanent issues or at least long-term issues that could be relevant to disability. There are people who have had to leave their jobs to manage things like virtual school or stay home with people. So I'm very worried about what it will do to people's optimism and sense of a return to normalcy as that seems further and further away as time goes on. And so I really, in therapy, try to focus on those moments of being able to take care of themselves, to connect, and those types of things. But it's really hard against the backdrop of these huge, valid, stressful issues. And so I think that people are really fatigued from pushing against that and trying to stay optimistic, and at least many people that I meet with are.
I was at my children's school the other day, and someone mentioned how their child had never not known wearing a mask to school and living through COVID. And I said, what do you mean? Well, my child's in first grade. You know, they started in preschool and kindergarten and now first grade, and they've been wearing a mask the entire time. And they just feel like it's an important, or it's a normal part of life at this point. And I think it'll be years before we really understand the impact that this had on our kids as well. Additionally, what scares me is that a lot of people who become adults and have mental health disorders, substance use disorders, suffered from childhood traumatic events, and it's just unknown at this time what kind of trauma this is really instilling on our youth and our younger generations.
And I really worry about that too. This, as you said, the social isolation paired with traumatic losses.
Yes.
So many children have lost their parents and loved ones.
Yes. So switching gears a little bit, Dr. Gordon, I would like to really know what motivated you to get into the field of mental health and psychology, and second, what motivated you to write this book?
Well, my father is a therapist, and so I kind of grew up around mental health being something that was openly discussed and something that was valued. And I always was just really interested in getting to know people and how they think, and also really pulled to try to help people who were struggling. And so that led me into psychology, and I just loved it more and more the further along I went with it in school. With this book, it was really a goal of mine since maybe the beginning of graduate school, the idea of being able to gather scientific information and clinical information, and then put it in a language where the public could learn and become educated about these things and find help and find tools. And so my deepest hope is that people who are suffering find some relief and some understanding of themselves through this book.
Yeah, and what I really liked about it as well is, as a psychologist myself, treating patients who usually had major depressive disorder or a host of other comorbid or co-occurring conditions, the suicidal piece was incorporated into the treatment plan along with the depression. What I love about this book is that it makes that a extremely important part of the treatment, but going through the exercises and the worksheets and a lot of the validation that you give along the way, I thought was excellently done. And it will also help to alleviate depressive symptoms and really kind of works on changing those distorted thinking patterns as well. So it's a very nice complement to therapy. It's something that you can utilize on your own, and it can be a very powerful tool for therapists and patients to work together on in the course of a treatment episode.
Thank you for saying that. And some feedback that I've gotten, for example, is that certain people are just uncomfortable talking to a therapist, no matter how much stigma has been reduced.
Yeah.
And so being able to privately work on a workbook is an option for those individuals too. And it does put suicide at the forefront. It's very clear in the title that people know that that's what it's about. But once it's past those crisis planning stages specific to suicide, it's really about having skills for living a high quality life, having a life that you want to live, not just preventing suicide, but creating the connections, meaning, and hope that make life worth living.
Absolutely. Dr. Gordon, how can people get a copy of your book?
My book is available at most places like Amazon, Barnes & Noble, and through my publisher, New Harbinger, as well.
Great. And for family members or loved ones or people who are struggling with suicidality, how can they reach out for help? What resources are available for them?
The National Suicide Prevention Lifeline is a great resource, and that phone number is 1-800-273-8255. And that is a great way to call. There will be people available 24/7 to provide assistance, whether you yourself are struggling with suicidal thoughts or you're concerned about a loved one.
That is our show for today. Thank you again to Dr. Gordon for joining us to talk about the incredibly important topic of suicidality. My name is Dr. Bender of the BeWell Network. You can learn more about us at BeWellNetwork.com. You can reach out to us 24/7. And remember, hope is available and you are not alone.